Good afternoon, everyone. Welcome again to St. John's Riverside Hospital's webinar presentation. Today we are going to talk about listening to your heart. So before we begin, I would like to thank my team, Jason Latour, our media production manager, Nancy Anabi, our community liaison, and Candace Cousins-Hopkins, our associate director of external affairs. They put all of this together for us, and I thank them for their hard work. I am Denise Mananis. I'm the Assistant Vice President for External Affairs for St. John's, and today's presenter is Dr. Alon Gitig, who is a cardiologist in our community. But before we get to it, a couple of things I'd like to do. One is to acknowledge our partners in the community. Sally Pinto is from the Yonkers Neighborhood Naturally Occurring Retirement Community, and that is actually under the umbrella of the Yonkers Office for the Aging and the Westchester Jewish Community Services. Also, Z. Baird, who is from the Yonkers Public Library, and they have 3 locations, the Riverfront, Will, and Crestwood Libraries. To our audience, we have a Q&A bar available if you have questions that you would like us to address at the end of the presentation, at the end of the discussion. Feel free to go in there, post them. We will be looking for those and we'll get them answered for you. So today I would like to very much welcome Dr. Gitig and tell you a little bit about him. Dr. Alon Gitig is the Director of Cardiology for Mount Sinai Doctors Westchester and the Medical Director of the Mount Sinai Heart Failure Alliance. He is a non-invasive cardiologist with 15 years of experience managing all forms of chronic cardiac diseases. He has been recognized by his peers for his expertise in the field of each of the last 7 years as a Castle Connolly Top Doctor selection and has been honored in Westchester Magazine and New York Magazine for these achievements. Dr. Gitig's clinical passion is in prevention of disease. He is particularly interested in lifestyle changes that improve the function of our heart and arteries, and which have results that go beyond the effects of prescription medicines. His practice focuses on nutritional interventions, exercise, stress management, and sleep optimization to achieve optimal targets for lipid levels and blood pressure, and also help to optimize patients' blood glucose and insulin balance, as well as systemic inflammation in the body. All of these factors can have a marked impact on our likelihood of developing cardiovascular and other diseases over the course of our lifetime. Dr. Gitig believes that by using state-of-the-art diagnostic tools, it is possible to personalize the assessment of an individual's risk for disease, as well as tailor interventions to those that are most likely to benefit a given person. In his experience, this approach is far more powerful than one-size-fits-all lifestyle or prescription advice. He does practice in Westchester County, Yonkers, and Scarsdale locations and sees patients both in person and via video visits. So Dr. Gitig, thank you for being with us and welcome.
Thank you so much for having me, Denise. It's great to do this.
I'm so glad you're here. So we're going to start with some very basic questions. The first of which is, what is cholesterol?
So I'm glad we're talking about this because I think that it's not talked about enough in clear science-based ways, and it's talked about way too much on the internet in muddled and unclear ways, which leads to a lot of confusion for people, including confusion for doctors. Some of the answers around cholesterol are not totally known. But a lot more is known than the internet would have you suggest, would have you think, which, kind of leaves you with the impression that, well, nobody knows if cholesterol is a problem or not. Nobody knows what we should eat. There's always differences of opinions. I'm just going to go do whatever I want and hope I don't get heart disease. And that's not really the case at all in my experience. So first of all, from a very basic standpoint, understanding it and demystifying it can help a lot. Cholesterol, first of all, in and of itself, in the right amounts and in the right places in the body, is not dangerous and it's not a bad thing. We have cholesterol in our body for a reason. We need it there. It serves several important biological functions. All cells in our body, their cell membranes are made up of cholesterol, and it imparts very important features that are absolutely vital for the cells to stay alive and function optimally. There are many hormones in the body, including sex hormones that are made in different tissues that have cholesterol as building blocks. There's other functions of the body as well that cholesterol has, and in the right amounts, in the right places is very important. One of those places, just to name one of a few, is the brain. The cells in the brain, the neurons, cholesterol is very important in their cell membranes. Their membranes are very important for signaling. So, for instance, we know that, if you have a newborn baby or a toddler who hasn't been introduced to McDonald's or ice cream yet in their diet, they don't have zero cholesterol in their bloodstream. They have some, because cholesterol is being trafficked through the blood to different places and it's being used by cells. The problem becomes when cholesterol gets into the wrong places, specifically the walls of arteries. What I will just say briefly here is that the walls of our arteries are supposed to have certain compositions that have functions that keep the arteries working normally and keep them healthy. And when things change and you start to get cholesterol out of the bloodstream stuck in the walls of the arteries, it leads to problems involving immune cells and other things that cause plaque buildup. So yes, cholesterol is important for lots of functions in our body, but yes, cholesterol is the ingredient in plaque. So when somebody has a blocked artery or a heart attack or stroke that is triggered by a plaque in the artery wall, the contents of the plaque were cholesterol. Certainly at the beginning when the plaque starts to form, and then sometimes it's replaced by other things. So there's no disputing that. That's very well understood. And as far as science tells us, the cholesterol gets there by coming out of the blood and into the artery wall.
So there's, in my limited knowledge, there are two ways that you have cholesterol. You manufacture cholesterol, and you attain it through food. Can you give us how people end up with plaque in the arteries, which is made up of cholesterol?
So that's a great starting point question as well. And if you line people up and you draw their blood and you look in the drop of blood, what's the cholesterol in their bloodstream, there's going to be a wide range of numbers, right? So all of us have different numbers in that respect. The cholesterol in the bloodstream gets there through two major pathways. One you mentioned spot on, you make it. So let me say this. I told you cholesterol is needed by every cell in the body for the cell membranes, and some cells need more to make certain hormones. Every cell of the body makes cholesterol. They don't just sit there and get it delivered through the bloodstream in these LDL particles. And many experts believe that in the vast majority of people, pretty much the cells of your body have plenty of cholesterol for their biological functions, just based on what they're making. They don't seem to suffer if you decrease the amount of cholesterol in the bloodstream. So that's an important concept. Now, of course, there are exceptions to every rule, and some people will be more sensitive to lowering levels in the bloodstream. But for the most part, the amount of cholesterol in your bloodstream has nothing to do with how much cholesterol exists within the cells of your body, because that's being made by the cells.
Okay. So then the cholesterol in the blood is really where we have an issue, because that's what gets stuck in the arteries.
That's right. And then the question you asked is, where does that level of cholesterol come from? Where does the cholesterol in your blood come from? And the answer is mainly two places. Your liver cells make a lot of cholesterol, because your liver doesn't just need the cholesterol in its cell membranes like all the other cells of the body. Your liver also puts some cholesterol into bile and secretes the bile. Cholesterol is part of bile, and it makes things called lipoproteins. These are the vehicles that carry the cholesterol molecules in the bloodstream. So everybody, most people at least, have heard of LDL cholesterol. That's measuring the cholesterol content in your LDL particles, your low density lipoprotein particles. These are one of the vehicles that your liver is synthesizing all the time, packaging hundreds of molecules of cholesterol into these little balls and then spitting them out into the bloodstream. So that's one place it comes from, how much your liver makes and spits out into the blood. The other place is how much you absorb back into the body from your intestinal tract. Okay, and that's where the diet comes in. So our liver is constantly making cholesterol and packaging it into these LDL particles and secreting them into the bloodstream. But your intestinal lining cells are constantly seeing cholesterol at their border and absorbing it back into the body. Now, it turns out that most of that cholesterol is not from what you eat. The vast majority is getting there through the bile. The amount of cholesterol in the food we eat represents a small amount of the total cholesterol that our intestines are seeing, and that's why eating cholesterol usually does not have much of an effect on what the cholesterol levels are in your blood.
Okay. So, you talked about the LDL. I know that's that's something that people who do have cholesterol issues are aware of. There's also something, the HDL, LDL, and then there are numbers assigned to those, and then there's a ratio number. Yeah. And as somebody who has some issues along these lines, I still not quite sure what the ratio is and what those numbers really mean. Can you just address that?
Right. So first off, what I will say is that we call LDL cholesterol bad cholesterol, and we call HDL cholesterol good cholesterol. The actual cholesterol molecule looks identical and functions identical if it was just living by itself. This, picture this is a ring, which is the shape of a cholesterol molecule. But what happens is your liver and intestinal lining cells and other places in the body, but let's simplify it. Your liver cells, they're making cholesterol, and again, they're not secreting the actual ring cholesterol molecule into the bloodstream. They're packaging hundreds of them into these individual lipoprotein particles. And each of these particles has a whole bunch of cholesterol in it and some other lipids that we won't get into, as well as some proteins. And if it's assembled in a certain way with certain proteins, it's an LDL particle. It functions and behaves as an LDL particle. Okay. If it has other proteins, it functions and behaves as an HDL particle. The reason we call them good and bad is because the LDL particles are both LDL and HDL particles are floating in your blood at all times. Right. And they're both constantly banging into the walls of the artery, right? Because they're in the bloodstream getting carried through the artery. And some of them are slipping through and getting into the wall of the artery where you don't want them, because that's where cholesterol can cause plaque. Okay. The difference is this, and this is absolutely key to understand. The LDL particles often will move right through the artery wall, and then they get reabsorbed on the other side back into tiny blood vessels, and they're out. But some of them, in the wrong set of circumstances, can get lodged there. And that's when they get stuck there and undergo chemical reactions. That's an LDL particle that now starts plaque formation. The HDL particles, the high density lipoprotein particles, they're carrying cholesterol, but they don't get stuck in the artery wall. That's why they don't cause disease. Because an HDL particle, if it enters, bangs into the wall of the artery and goes in, it'll go out the other side and it won't get stuck. So it can't cause plaque.
So
by the way, before we get off that, the other reason they're good is not just because they don't do bad things. It's not just because they don't cause plaque. It's because they actually accumulate cholesterol. They take cholesterol from other particles where it can cause problems, and they bring it back to the liver where it gets secreted into the stool. So the more of those good particles, HDL particles you have, the better off you are, because there's less cholesterol available to get stuck in the artery wall.
So the ratio then is very important, that it's more HDL, less LDL, and there's I don't know what the sweet spot is, but you, as a cardiologist, you're looking for that ratio, more HDL, less LDL.
That's exactly right. Everybody wants a ratio in that direction. And then, they've done dozens and dozens of research studies over the years where they look at every cholesterol number you can think of. The LDL cholesterol number, the number of LDL particles, the HDL, the ratio. There are some other things that they look at, and they run these things through big databases of lots of people, and they see what is the most predictive to predict future risk of heart disease, heart attack, stroke. So it turns out that the LDL-HDL ratio doesn't really predict significantly better than knowing the number of the LDL particles in your bloodstream. And that's why we don't tend to focus on that. But yes, the more LDL you have, the worse it is. The less HDL you have, the worse it is. So you want more HDL and less LDL.
Okay. So the one thing that we didn't really talk about with cholesterol, and then I do want to move on, is is it something that is hereditary? In other words, can you inherit a predisposition to manufacture cholesterol, even if you're young and fit and, you know, eating well and doing all of those other things? Is that something that occurs?
So the answer is a definite maybe. The truth is that no, it's for sure possible. Many people have inherited that. I see those people in my practice all the time. I mean, just yesterday I saw a rail thin woman who has a very bad family history and does everything you could ask for exercise and diet wise, but has had high cholesterol since she was in her 20s. So the thing about it is, we talked about producing too much in your liver. There are this field is expanding because the tools to do research and understand genetics have exploded in the last 10, 15 years. We're learning more about different genes. We're learning what their functions are and then how to identify them and test them in people. But there are known genetic variations that cause people to produce too much. There are things that cause people to absorb too rapidly from the intestines back into the body. And then there are just to complicate things more, once your liver makes whatever amount of cholesterol it makes and puts that in whatever number of LDL particles it puts it into, those get secreted into the bloodstream. You are actively removing LDL particles from the bloodstream all the time at your liver cells. There are receptors for LDL in the liver cells. And the amount of those receptors and how efficient they are at clearing LDL particles from the blood is also very genetically driven in some people. So the answer is that it's definitely an issue for some people. The field of being able to go not in a research lab, but in someone's office and get tested to determine the mechanism of their high cholesterol, that exists now. Right now you can do that, but it requires only one specialty lab in the US that does that testing. And then understanding the actual gene variants you have and what that means about risk, that's a field that's not yet ready for prime time, but it's getting close.
Okay. So, you know, in my lifetime, I've been hearing about cholesterol and heart disease and all the advances that have been made. But maybe for our audience, you can give us just a little bit on what evidence is there, because there's a lot of debate on taking cholesterol lowering medications. And so what evidence exists on lowering, on the idea that lowering your cholesterol protects against heart disease?
Right. So I'll start with what we don't know. What we don't know is what is the blood level of LDL cholesterol that God or evolution intended us to have. We don't know that for sure. And that's where the debate comes in. And we don't know that for sure because the timing of in history, when we developed the tools to even measure cholesterol and understand its role, came at a time after the Industrial Revolution when everything changed as far as our exercise, our ways of getting food, our abundance of food. So we're basing this understanding on deducing things from what certain things we know and studying societies today that still live similar to what we lived before the Industrial Revolution, as well as looking at people that have certain genetic abnormalities that lead to either very high or very low cholesterol. We definitely know, like I told you, that if someone has plaque in their artery walls, the cholesterol is what forms that plaque. So it makes sense, and it is likely the case, that if you had no cholesterol anywhere in your bloodstream, you could never form plaque. Now, you might have other problems. There's a whole bunch of reasons why that might not be good for you in general, but cholesterol is a necessary building block. We do know that when you take tribal societies, okay, there's a tribal group, I think they're in Bolivia, where they have made contact with them, local researchers, and over the years they've done these high-level CAT scans to look for any evidence of plaque in their arteries. And they've studied a wide range of people, including into their 70s and I believe 80s. They don't get plaque, period. It's not a disease of this group. It doesn't exist. those people's LDL cholesterol on average was in the 70s range, okay? Interestingly, by the end of the years they were studying them, it went to the 90s. And the reason it went to the 90s, they think, is because they developed motorized boats. They got access to motorized boats. And now they were able to get to town and buy things at the market instead of hunting for all their own food. So that's been done in many other societies that seem to be totally free of disease. In Okinawa, Japan, it's one of what you hear about as blue zones, where there's longevity and not much chronic disease. The average LDL cholesterol there is also somewhere in the 90s. Several hunter-gatherer societies have LDL cholesterols that range in the 50s to 70s range. So that's one important piece of evidence. We also know that when babies are born and when toddlers are going through rapid development and they're undergoing the most rapid brain development that a human undergoes, their LDL cholesterol is in that 40, 50, 60 range. And it clearly doesn't limit, their healthy development of their other organs. So those are, and then the last piece of evidence on that front, and we're not talking about medication lowering yet, we're talking about what's a good target. In people who have genetic abnormalities, who live their lives with LDL cholesterols anywhere from 20 to 70 or 90, somewhere in there, those people at later ages, even once they're diabetic and once they're smoking, not huge numbers, but small numbers have been identified in families or in certain communities, and they just do not have plaque and they don't get heart attacks or strokes. So there's a strong evidence that in real life, these numbers are very protective of the arteries. Then you've had lots and lots of studies of medications lowering cholesterol.
Right.
Okay. Now the debate here, I won't get into all the details, but so the vast majority of those studies were done with a class of medicine called statins. Right. Then we have 2 studies done with a different medicine and 2 studies done with a third medicine. Okay. All of those studies have shown that if you start off with a group of people who's at a high enough amount of risk, you're going to see lowering of risk of heart attack and stroke. Okay. These studies are not going to go on for 20 to 40 years, which is the time frame of these other tribes and the genetic studies that I'm telling you. When you meet the people in their 40s, 50s, 60s, they've had a lifetime of low cholesterol. Here, you're taking someone who's had cholesterol at a certain level for many years. It may have started forming plaque, and then you're lowering it. And you're studying them for at most 5 years. A couple have gone 7 years. It's usually 2 to 5 years. If the people have had disease already, so they're in the highest risk group because they've already had a stent or a heart attack, the vast majority of these studies show that you'll lower the risk of heart attack and stroke. And every time they do these studies over the years, they've gotten more and more aggressive about how the dose they're giving. And then they see lower levels of LDL cholesterol. The risk seems to clearly be lower at every lower stage of LDL cholesterol.
So are these medicines just targeting the LDL cholesterol? Do they lower both the LDL and the HDL?
So the medications lower LDL cholesterol and typically do not change the HDL at all.
Okay.
HDL is a very complicated topic. And what I will say is this, it's not a target of therapy at the moment. We have no drugs that can raise it. And even checking the blood test for HDL cholesterol is not totally accurate. You need to know the functionality of the particles. We know that people can have very active, in a good way, very active HDL at lower levels than some people who have high HDL cholesterol. We don't have clinical testing for doctors to use to test functionality. But so these medications, typically the only thing they're doing on your lipids is lowering LDL cholesterol. They might lower triglycerides a little bit, probably not a big issue for risk. And the vast majority, not every single study, but the vast majority show that they reduce the risk of artery disease.
So then why is there such amount of negative press on these drugs? Are the statins, are the side effects so difficult for people? Because honestly, I'm very skeptical myself about taking a statin because I've read, the media says a lot of things. What is your take on the safety of these drugs, not just side effects, but also long term? taking these drugs?
So first of all, I think your skepticism is good. I mean, that's healthy, and I'm generally very skeptical as well myself about introducing new compounds that are not well studied. And until about 2 years ago, I actually was less aggressive at how much I lower cholesterol, because I always had this concern that, well, if people walking around have an average LDL cholesterol in this day and age of 120 or 130, am I doing the right thing by pushing it much lower? It's only since I've digested all the information and really dissected what I'm telling you that I've become pretty convinced that our bodies were intended to be at much lower levels. The reason for the debate, there's a few reasons that I can give you. One is because many people in the world are just, from a starting point, very suspicious of drugs, the pharmaceutical industry, the fact that, profits drive a lot of the decisions, and there have been some scandalous cases where profits have driven how papers were reported and things like that, and all of that is true, but I believe very much an outlier, an exception, not the rule. The other thing is that I told you that the vast majority of studies have shown that these medications, when they lower cholesterol, will reduce heart disease and stroke risk. Not every single study has shown that, and some people have latched on to the few that haven't. And in most people, unless you've had a heart attack, for most people, the studies, especially for the healthier lower risk group, do not show that it prevents overall deaths. It'll show that it reduces heart attacks and strokes and prevents cardiovascular deaths, but it doesn't prevent overall risk of dying. And so many people will say, well, ultimately, if it's going to lower my risk of heart disease deaths, but it's not going to lower my risk of overall deaths, it must be causing me to die from something else. There's a skewed reasoning there, though. When you study someone for 2 to 5 years, you're probably not going to be able to show that you reduce overall deaths. It takes many, many, many years to show that kind of health benefit. And so I don't believe personally that the lack of showing that you'll prevent overall risk of dying is a knock on these medications. I think that if studies were done where people were given them for 20 years versus people who weren't given them, you would see that the overall risk of dying went down. There are side effects to these meds, but it's better studied and understood than any other medication in the world. And the overwhelming evidence suggests that there are not common and not very severe or mysterious or nefarious side effects. There are things we understand and we know how to look for them, and we know how to reverse them if they happen.
Can you give me an example of one or two of those?
Absolutely. Yeah. So probably about 15% of people get muscle or joint pains or muscle weakness on statins. And you'll talk to people out in the world, or you'll read on blogs, oh, statins were the beginning of the end for my grandmother. She was on it for 20 years. She kept having weakness. The doctor just kept ignoring it, and she became a cripple. Well, what I would say is that's not the medicine. That's the doctor. Okay, if you start someone on a medicine and you appropriately interview them and try to find out, oh, you're having trouble standing up from a chair now, your legs feel weak, you give them a trial off the medicine. If it's from the medicine, it goes away and you don't put them back on that medicine. So that's my point. It's not a crippling, inevitably progressive problem. And I would say that that's probably true in more than 99% of people who are affected. The other fairly common one is it can raise blood sugar, and it can cause new onset diabetes. That's a big problem because that can cause heart disease and stroke, even at low levels of cholesterol. But that's not hard to find. If you're just paying attention, again, it's tempting when we're working fast in a doctor's office to say, oh, now you're diabetic. Well, that's because 1 out of every 8 patients I see is diabetic. You're not exercising enough. If you're thinking and you're saying, well, could this be an effect of the med I started you on a few years ago? Then you stop it, you see if the blood sugar improves, and then you have a conversation with the patient about the risks and benefits.
Interesting. So there are the statin drugs, which you're referencing. There are some new drugs that are not in that class. And then the other question, which I know a lot of our audience is interested in, is are there homeopathic or holistic or natural medications that can help?
Right. So let me be very brief on the other classes of drugs, because I think the other stuff warrants more discussion. There are 2 other classes. One is just one medicine called Isetamide. The brand name was Zetia until it went off patent. People probably heard of it. It blocks that absorption from the intestinal inside of the intestines back into the body. That medication has extremely few side effects that have ever been seen. It's not new, it's been out for many years, and it can be extremely helpful in lowering cholesterol. And we actually have 2 studies that show a statistical significant reduction in risk of cardiovascular disease. It's a pill. The other class is something called PCSK9 inhibitors. Don't worry about the acronym. It's a medication that is a man-made antibody to target a specific enzyme and inhibit the enzyme. And it's an enzyme in the liver that regulates how many of those receptors are on the liver surface that are constantly clearing LDL out of the bloodstream. So the LDL particles are going through your body in the bloodstream, and when they come back to the liver, they attach to these receptors and they're cleared. This enzyme plays a role in how many receptors there are on the cell surface. And when you give an inhibitor of the enzyme, you get many more receptors on the surface, and you can very, very dramatically lower your blood levels of cholesterol. And it was actually created because they discovered this genetic variation in humans and what it did. Those are one example of people that live with LDL cholesterol in the 20, 40, 70 range and seem to never get artery disease. And as far as we can tell, they don't get other health problems either. So that's a separate class of medication. The 2 meds are called Repatha and Praluent, and both of them have been studied in high-risk groups and shown to be very protective. In only under 3 years, actually, they moved the needle on disease risk. Both are very well tolerated. So far, from what we see with the newer ones, they've been out for about 5 years or so. There's seems to be really very little bit in the way of any kind of symptomatic side effects. And at this point, we haven't noticed any lurking, dangerous things, blood sugar, etc. You also asked about long-term, by the way. We don't have randomized trials that last 20 years, but we do have trials that they continue to follow people for much longer and analyze data based on whether they're taking the medicine or not. One of the biggest concerns people have is that my brain cells need cholesterol, and this is going to get into the homeopathic discussion as well. My brain cells need cholesterol to function well because it's in the cell membranes. So if you lower my blood cholesterol too much, it's going to somehow deplete the cholesterol from my brain, and I'm going to get dementia or I'm going to get forgetful. Very complicated discussion, but what I will say is this. We know for a fact that very, very rarely, and I'm going to stress very rarely because I've now seen many thousands of people probably on statins, and I've seen this only 2 or 3 times. People can have a clear memory deficit related to starting a statin. It is a strain. It happens in people also who aren't on statins, this term for this condition, but there are some people who it seems to happen when they go on a statin, and in very rare cases, it seems to happen again when they restart a statin. We don't think. So I told you before, the blood levels of your cholesterol probably do not determine at all what's going on within the cells of your body. They make their own cholesterol. And the studies of brain cholesterol suggest that they're totally doing their own thing. They are not retrieving cholesterol from the bloodstream to use inside of them. They're making their own cholesterol, and they're doing it at a rate that it lasts a long time there. So we don't think these medicines affect that. And we don't know why some people get this side effect. But they have done intensive studies with very intensive neuropsych testing on people given potent cholesterol lowering meds, and they don't see any ill effects.
So basically, this is the drug of choice then if you're going to go that route to lower your cholesterol and your risk.
Yeah, but I mean, in terms of, so any of these medicines seem to do good things, but the statins do other good things. We won't have time to get into it, but it's not all about cholesterol. The processes going on in the artery wall that lead to plaque have to do with your inflammation in your body, how active or not your immune system is, how overactive, inappropriately activated your immune system is, as well as something called oxidative stress, how much overloaded the tissues in your body are with these things that we produce all the time, but we normally inactivate them, called reactive oxygen species. Statins improve significantly the oxidative stress and inflammation in the body, and that's probably a big part of how they work. So So those are the medicines.
Can you touch on the homeopathic or the natural?
Absolutely. So
And
the
then
first,
change topics.
yeah, absolutely. The biggest thing in terms of a natural approach before talking about homeopathic, well, not homeopathic, that's actually a very specific term, but naturopathic, we'll say, is diet and exercise. Now, totally variable how much a person's cholesterol responds to these things. Okay. There is not one thing that is relevant to everyone. In general, cholesterol you eat does not change your blood level of cholesterol. So what has cholesterol in it? By far, the most is in egg yolks, by far out of anything. Second most is shrimp. And then beef and animal meats is a distant third.
So I actually have a question here from an audience member who asked if eating an egg, given what you just said, will negatively affect the desired amount of cholesterol in their body.
The answer is it very rarely affects it. And that's because, remember, I told you the overwhelming majority of the amount of cholesterol that your intestinal cells is seeing to reabsorb into the body is coming from the cholesterol you produced and made into bile. It's only a minority coming from what you eat. There are some people who absorb every last bit of cholesterol their intestine sees because they have a genetic variance in that absorption pathway. And for those people, eating cholesterol like eggs may affect it. There are certain tests you can do to predict if you're in that group, but mostly it's just trying it and seeing. For most people, but not all, the amount of cholesterol in your blood is going to be much more impacted by the amount of saturated fat you're eating. That's different than cholesterol. Those are different things. The amount of fatty acids you're eating that are what we call saturated fatty acids. That's mainly found in dairy fat. Okay, so milk, yogurt, butter, cream, cheese, and in fat content of meats. So fatty beef, dark meat chicken, and skin has more of it than other types of chicken. For most people, that's going to influence their cholesterol levels because it impacts how your body clears cholesterol from your bloodstream. But that's not the case for everyone either. And so it's really got to be individualized. You try things and you see what happens. And then for a smaller percentage of people, it actually could be much more about the carbohydrates. So for some people who reduce their carb intake significantly and lose weight with that, you will see their cholesterol improve. Weight loss can lead to significant improvements in cholesterol no matter how you achieve it, but it doesn't always. Intensifying your exercise, doing cardio exercise and strength training can lower cholesterol, but it doesn't always. So it's not that, oh, nothing works, I'm just going to do what I want because nobody knows the answers. It's that we don't know the answers of how to predict in every given person right now. But if you work with someone involved in intensive prevention, they'll guide you on trying this or that. And if you try it for 2 months, 3 months, you'll have your answer.
So what you're saying then, from a natural approach, it's the exercise, it's the diet, it's avoiding those things or trying those things to see if it has an impact on the numbers. What about, and certainly stress reduction, I'm sure, finding ways to lower one's stress in daily life. But what about homeopathic medications or medicines or counter stuff?
Yeah, so definitely you're right. Mental stress is a big one. We shouldn't discount that. I've seen plenty of people whose cholesterol goes up during times of stress. There are naturopathic remedies that can lower cholesterol, but not many of them, and they don't do that much. One of them is called red yeast rice. That's the one that's most likely to work. It's a type of compound that is made by cultivating a type of rice in the presence of a certain type of fungus that creates a certain compound in the rice, which acts like statins. And actually, that's how statins were invented. It inhibits the same enzyme in the liver that diminishes how much cholesterol your liver makes that statins do. But it does so without any added chemicals or fillers or dyes that the pills have. And it's much less potent. So it tends to lower the cholesterol less, and it tends to be tolerated better without side effects. Some people, depending on how much they produce cholesterol in their liver, will have a good effect by using red yeast rice. If you're a very high-risk person who needs very low levels of cholesterol, it's hard to achieve it with red yeast rice. But I've had some people who can tolerate really, really high doses of it that start to...
It's a
It
cap.
comes in, yeah, it's in capsule forms. So the other thing you have to keep in mind is that companies can make capsules that don't get absorbed in the part of the GI tract where they should. And so you pay for it, you take the red yeast rice and you poop it out and your cholesterol doesn't change. So there are certain companies that are much more reputable than others in terms of putting time and money into product design, as well as putting time and money into testing the ingredients and making sure there's no toxins and adulterants. But when I use those products from those companies, we will sometimes see pretty good cholesterol reductions. Sometimes we have to gradually go up on the dose, up and up, until it gets to a point that's similar to a statin at a low dose. But some people, for whatever reason, I can't tell you, still tolerate that better than they do the statin.
Interesting.
That's the main one. You will go online and you will read about artichoke and you will read about fiber and all these things. Typically, if you buy those and use them at the dose on the label, the recommended serving, you'll get nowhere. If you work with an experienced practitioner, and I'm not highly experienced in all of those options, and they push the dose high enough and they put you on 2, 3, 4, 5 of them, you may get somewhere. I will say that in a select minority of people, something called berberine can actually be very effective if used at a high dose, because it acts on those LDL receptors and it changes the number of those receptors that you have. And some people respond nicely to that.
So when they're selling you 2 capsules for 30 days, every day, on some of these, because I see it constantly now online, it's really not having an effect. It makes you feel good about yourself that you're trying something, but there's a lot of stuff out there that says that it lowers cholesterol, and so that's very interesting to me.
Yeah, and you'll see. So that's a perfect example. They're going to recommend you take 2 red yeast rice capsules a day, and in my experience, to really budge the number, you're going to at least need somewhere between 4 and 8 a day. So that's a perfect example.
All right, I would like to turn this subject because I don't want us to run out of time, but I do want to talk about high blood pressure and the relationship to cholesterol, or maybe just its impact on coronary artery disease, and what our audience needs to know. So, if you could explain the 2 numbers. And by the way, we didn't actually talk about the right numbers to reach for cholesterol. And obviously I want you to tell us the right numbers, because they do change. The news keeps reporting, 220 was good for a total cholesterol at one time, but now it's got to be under 200. And so same thing for the blood pressure. What is the agreed upon numbers that we should be looking for?
Yeah. So the general concept, both for blood pressure and cholesterol, is that if you're doing it on your own, if it's your genetics or your body weight and diet and exercise, every study pretty much shows that the lower it is, the better for cholesterol and blood pressure. Down to a top blood pressure number of about 115. Okay, so if you're walking around like that, you're going to be even lower risk than someone who's 120 or 125. But that's very different than saying what's the ideal level to lower it to with exogenous substances. So, your blood pressure, there's a top number, a bottom number. It's called systolic and diastolic. The names just have to do with the pressure in your artery is generated either by your heart squeezing and suddenly pumping blood out through the arteries, that's going to raise the pressure, or your heart is relaxed, it's in between heartbeats, the system is sort of a pool, a lake of blood just hanging out, there's a pressure in that, that's your bottom number, your diastolic. They're both important. Higher numbers of either increases risk. There's not any convincing evidence that one matters more than others. And we now have, I would say, the guidelines have changed because we now have evidence that when I say lower is better, down to about 115 on the top, we now have evidence that if you're treating someone with medications, getting them even lower than we used to think, getting them under 130 on the top number, and under 80 on the bottom number with medications will prevent even more heart attacks and heart disease and stroke. That used to be 140 over 90, and now we've lowered it to 130 over 80. The thing is that, you really cannot say there's a target for everyone. It really has to be based on the person's risk. Because if somebody's had already 2 stents close off or 3 bypass surgeries, you don't have to even be so knowledgeable in this area to say, well, whatever we're doing isn't working. Your arteries are still soaking up lots of cholesterol, even if your LDL cholesterol is 60, so you need it lower. It really depends on the person. So the guidelines try to give risk thresholds, analyzing people's risk using estimating equations, and give ranges based on that. But in my experience, even that is not personalized enough. You really need to dive into what is this person's risk sitting in front of me. And we know that the deeper dive you do in that regard, the more you find things that deviate from what those risk equation calculators suggest. So to do that gets into a whole different topic where you try to see, number one, do people have certain biomarkers, blood tests that indicate higher risk? And number two, do their arteries show that they're starting to build up plaque? And are they building it up a lot more than expected for their age? So there are some tests like things called coronary calcium scans, which can give you an accurate percentile of where you rank among your similar age peers. And that's a very useful test because if you're way down the path of plaque formation, I have patients whose arteries are 20 years older than they should be. They clearly need lower blood pressure and cholesterol. So to touch on the high points before we run out of time, blood pressure is important because what we call shear stress, the stress on the walls of the artery, the cells lining the artery, creates damage over time. And by the way, let me stress over time. If you on a Friday check your blood pressure at the CVS and it's 140 or 150, you do not need to live in dread that over the weekend you're going to have a heart attack or stroke. It's way less than 1% likely that blood pressure is going to harm you in the short term. I tell that to people because it puts it in perspective. But over long periods of time, the high blood pressure stress on the walls of the artery creates damage in such a way that activates signaling that makes it more likely for cholesterol to get in, get stuck there, and then get engulfed by inflammatory cells and cause plaque. There's no direct relationship between your blood cholesterol level and your blood pressure, except that they often are high in the same people because the reasons to have high, yes, they can be purely genetic, but much more often they're related to being overweight, not exercising enough, being too high stressed, not sleeping enough, not having enough muscle mass, all the things, eating too much sugar and salt in takeout, all the things that we're drowning in our society. So they often go together in that way. And by the same token, the lifestyle changes we spoke about for cholesterol will also work for blood pressure, but I will stress they work much better and much more often to improve blood pressure than they do for cholesterol.
This is very interesting. So you talked a little bit about the numbers. If you're someone in the community who is, and this will probably be my last question, who is 40 and who has a blood test and it shows some of these things, I mean, can you start first with the exercise and the diet? Do you immediately go to drug interventions? When should you be going into drug intervention? Mm-hmm. When do you know that you need to really address this?
Yeah.
This is really the bottom line.
Right. So there's still a little bit of editorializing on my part here because there is no definite answer to this. It also depends on your perspective. I just want to say that if you go to a doctor and they treat you based on the guidelines, you have to understand what that means. The guidelines are saying, analyze this person's risk for disease in the next 10 years. And if that's above a certain threshold of likelihood of developing disease in the next 10 years, go to drugs. And that's true for blood pressure and cholesterol. And then reevaluate them every few years. Now, you can do that, but there is a school of thought, and I lean more towards this, that says, if a person has a life expectancy of 30 years, 40 years, okay, you're 50 years old. Many people live into their 90s nowadays. If you want to make sure you never develop artery disease in your lifetime, We don't know the exact time point when we can do testing on you and measure some outcome of the test and tell you, now you've reached a point where you can prevent it if you start now, but if you wait another year, you can't prevent it. So the only way to be sure you're going to prevent it is to start early and try to get everything really optimal. But that doesn't mean that if you don't do that, you're destined to have disease. In my opinion, I think early intervention is very important. I think that almost everyone can and should try with lifestyle changes first, improving diet, losing weight, improving exercise, improving stress, improving sleep. There are very few people who I feel are so high risk that something may happen to them in the next 3 or 6 months that it's dangerous to wait. But the other thing is that even if they are high risk, you can go on medications and make these changes and then start to pull back and see what your numbers look like. Okay, but because of how busy doctors are and how short our appointment times are, the patients really have to be proactive in that. You have to say to your doctors, I've lost 25 pounds. I really want to see how my blood pressure looks on less med, and talk to them about ways to do it safely. It doesn't just mean stop 2 medications cold turkey, but there are ways to do it safely. In general, if you take somebody who's 40, 50 years old, they have a long life to live. So there's a lot of time for their arteries to develop disease. It's a good idea to get things under control, but if their individualized testing does not show that they're at high risk, you can take a lot of time working on diet and exercise. You can take a year, 18 months, 2 years. And if it gets to a point where honest conversations suggest, I've done my best. I'm never going to lift weights 3 times a week. It's just not going to happen. I've done my best with diet. Then you say, okay, well, now we have a decision to make. Let's not spin our wheels and pretend something magical is going to happen. We know where we're at. Now you have to decide, do you want to err on the side of lowering these numbers because I believe as your doctor it's going to lower your risk? Or do you accept that you're going to be on a medicine that we know a lot about, but it's impossible to know everything about it? Or do you want to say, I'd rather just wait, keep doing the individualized testing every few years, and wait until I see that my risk is getting higher? And that's a person-to-person decision. And by the way, in their own lives, when I speak to doctors about what they do for themselves, people make different decisions. There is no one answer, but it's got to be, what we call shared decision making.
Very interesting. Doctor, I think we run out of time, and I just want you to know how much we appreciate all the time you've given us and how interesting this was, and actually how clear it has become. So I know what I need to do. With that said, thank you again, and I would like to bring up some slides. First of all, our contact information for Dr. Gitig is here. Again, he's got an office in Yonkers and one in Scarsdale. He has one phone number. If you'd like contact information because you didn't get this fast enough today, feel free to email us at info@riversidehealth.org, and we would be happy to send you that information as well. Going to the next slide, for anyone who is out there who is still uncomfortable with going into a doctor's office but does have a complaint or just finds this to be more convenient, please access our virtual urgent care, because certainly they can give you the heads up on whether or not it's something you really do need to come out for. And that number to reach it is 914-964-4429. And then again, info@riversidehealth.org, and for physician referral, find a doc at riversidehealth.org. Both of those come to me, so I will be happy to answer your questions or your inquiries. And I did want to say that if you are not following St. John's Riverside Hospital on our social media platforms, then you're missing out, because this webinar will be there, as well as all of the webinars that we have produced, our podcasts, and just general information and general events. So follow St. John's on Facebook, Instagram, LinkedIn, YouTube, and I'm forgetting one, whatever. We're out there. So follow us so that you know what's going on. And Dr. Gitig, thanks again. Really appreciate your time.
Thank you so much. I really enjoyed doing it, and I really hope I can clear it up for a few people, at least a little bit.
Very much so. Thank you.